This is the Chapter 60 Assessment PowerPoint recording. Okay, so we're first going to just talk about a little brief review of the anatomy and physiology of the nervous system, the central nervous system and the peripheral nervous system. So the central nervous system includes the brain, which includes the cerebrum, brainstem, cerebellum, ventricles, and cerebral spinal fluid, as well as the spinal cord. And then the peripheral nervous system includes the spinal nerves, cranial nerves, and autonomic nervous system. Okay, so we're going to talk a little bit more about the brain and the cerebrum specifically. So it is divided into right and left cerebral hemispheres, and there are 4 lobes. Now, in your book, it does talk more about the different characteristics of each lobe. I've just kind of put the main ones on here. Just make sure that you review what each lobe is responsible for. So for the frontal lobe, we've just included here higher cognitive function, memory retention, voluntary eye and motor movement, motor functions involved in speech production, or Broca's area, which will come into play a little bit later. The temporal lobe integrates somatic, visual, and auditory data, includes the Wernicke's receptive speech area. So once again, that'll come up a little bit later. The parietal lobe interprets spatial information and contains the sensory cortex, and the occipital lobe is included on processing of sight. So some additional structures, and make sure that you do refer to this table 60.1 in your textbook, but the basal ganglia, which is responsible for the initiation, execution, and completion of voluntary movements, learning and emotional response, and automatic movement associated with skeletal muscle activity. The thalamus is the major relay center for sensory input from the body, face, retina, and cochlear and taste receptors. The hypothalamus has a direct influence on release of hormones from the anterior pituitary gland. The satiety center and appetite, as well as body temperature, water balance, circadian rhythm, and expression of emotion. The limbic system is responsible for emotion, aggression, feeding behavior, and sexual response. So when we talk about all these structures of the nervous system and we talk about abnormalities of the nervous system, it's important to understand what that area is responsible for. Therefore, if we have an abnormality, then those items are potentially impacted based on whatever condition may be present. The brainstem, so that includes the midbrain, the pons, and the medulla. The ascending and descending fibers to and from the cerebrum and the cerebellum pass through the brainstem. So this is key. The brainstem is concerned with respiratory, vasomotor, and heart function. And so most people understand the significance of the brainstem, but we really want to make sure that you understand if we have an issue with the brainstem, it is typically an extremely severe problem that is highly fatal if there's a problem with the brainstem. And a lot of times we associate that with the respiratory centers, but as you can see here, it's also responsible for vasomotor and heart function. So if we have a brainstem abnormality, it is an emergent situation with a lot of potential impact to the patient. Also contains centers for sneezing, coughing, hiccuping, vomiting, sucking, and swallowing. The cerebellum is just below the occipital lobe and coordinates voluntary movement and maintains trunk stability and equilibrium. So I want you to think of the cerebellum and think of balance and coordination. And again, we'll talk about that a little bit more when we talk about abnormalities associated with the cerebellum, but it is important to understand the role of that part of the nervous system to then better understand abnormalities associated with it. Okay, the ventricles are, these are not the ventricles of the heart, but they are very similar, but they are fluid-filled cavities within the brain itself. So basically spaces within your brain. And the ventricles are responsible for the actual production of the cerebral spinal fluid. So the cerebral spinal fluid circulates within the subarachnoid space that surrounds the brain, brainstem, and spinal cord, cushions the brain and spinal cord, carries nutrients through passive diffusion and active transport. There's supposed to be about 150 ml at any given time. So there's fluid, that fluid is supposed to be there. And we will talk more about abnormalities associated with cerebral spinal fluid. But knowing that you can have changes in rate of production or absorption with associated neuro abnormalities and that will then impact the cerebral spinal fluid itself. So for example, too much cerebral spinal fluid results in what's called hydrocephalus, or too much of that on board. Will talk a lot about analyzing the cerebral spinal fluid. So testing the actual fluid to see what components are present, high, low, something that shouldn't be there. So we will talk about that more as well. We do measure the cerebral spinal fluid pressure in patients with actual or potential intracranial injuries. And that's important because increased intracranial pressure, which is often abbreviated as ICP, is something that can force herniation of the brain and the brainstem. So basically, our skull is not a movable structure. So if you have too much fluid within that, or if you have too much swelling, and we will talk about this in another PowerPoint, then there's nowhere for that to go. So what happens is it puts too much pressure on the brain and potentially the brainstem, and can cause what's called herniation, which is the actual movement of those structures into a place that they're not supposed to be. So it can cause pressure to the brainstem, then resulting in the brainstem not being able to function as it's supposed to, as we talked in a previous slide. Parts of the brain can actually move into those ventricles, into those spaces. And again, the brain tissue is not in a place that it's supposed to be. Therefore, we're not going to be able to function as it's supposed to be. So the spinal cord itself is continuous with the brainstem and contains ascending and descending tracts. The ascending tracts carry sensory information to higher levels of the central nervous system. Descending tracts carry impulses responsible for muscle movement. Reflex arc is involuntary response to stimuli. We will talk about that when we're talking about assessing a patient's response. Lower and upper motor neurons have associated with skeletal movement and skeletal muscle. Cerebral circulation. So we're talking about the arterial blood supply to our brain itself. So they initially come from the internal carotid arteries and the vertebral arteries. So those are structures that ultimately come off of our aorta and then supply our brain tissue itself. You might remember from anatomy class that we have the circle of Willis, which allows for the circulation to go to both sides of the brain, and that's kind of designed in a way to prevent, or to make sure if you have an issue on one side that you have adequate blood supply to the other one. We will talk to you about the blood-brain barrier, which is a barrier between blood capillaries and brain tissue, which is specific to that area, and some medications that do and don't cross the blood-brain barrier. So again, it's a protective mechanism that our body has to basically protect our brain tissue. Our other protective structures include our skull, which we kind of talked about a little bit before, the vertebral column itself that protects our spinal cord, and then the meninges, which are the protective membranes that surround the brain and the spinal cord. So those are categorized or kind of divided into the dura mater, arachnoid, and pia mater. And then the subarachnoid space is something that we will talk about a little bit more, which is used to actually obtain the cerebral spinal fluid during a lumbar puncture, which is a diagnostic test we'll talk about later. This picture just kind of shows you the meninges itself, and it shows you a little bit the brain and the ventricles, and kind of just puts a little bit of an image associated with what we've been talking about. And this one also shows you the circulation. So this will come into play also when we talk about strokes, because if you have a blockage in one of these arteries, then it impedes flow or arterial blood flow past that area of blockage. And so this kind of is a good image to kind of associate with that. Okay, so we do need to always talk about how as we age, what kind of effects of aging that might have on our different systems. And this goes for everything. This goes for respiratory, cardiac, musculoskeletal. So it's important to know what is associated with aging, to know that some findings that we may see are somewhat expected based on that patient's age. That being said, if anything that's new, we would always want to just evaluate, but there may be things that are kind of just associated with being, with as you age. So I do want you to review the table in your textbook 60.2, but some examples here are just difficulty with coordinated neuromuscular activity, difficulty in maintaining blood pressure in response to changing positions, which results in orthostatic hypotension. So as you've cared for patients in clinical or in practice, you've probably noticed that older patients do have a higher likelihood of orthostatic hypotension because their body just can't compensate as quickly as it should, or as it does in younger people, which is why we always say to make sure we just sit our patients on the side of the bed before we stand them up. But this just kind of explains that a little bit. Less able to adapt to extremes in environmental temperatures, decreased taste and smell, decreased muscle strength, decreased or reduced hearing and vision, and decreased or dulled tactile and pain sensations. So just kind of know that this doesn't necessarily mean that every older patient will have all these, but they may as a result of just aging. And also keep in mind that these abnormalities, they should be generalized versus a localized symptom or a unilateral symptom. So if I were to say that a patient has decreased muscle strength bilaterally, that may be related to an age-related abnormality. If they have decreased muscle strength only on one side, then that's not going to be a normal age-related abnormality, right? That is something that is probably related to something else and needs to have some further evaluation. So keep that in mind too. We would expect general bilateral symptoms with normal age related abnormalities. Okay, so if we're going to do an assessment of neurological function, we'll first start with subjective. So we would need a detailed health history. So history of symptoms. If we have a patient that comes in with a new neurological abnormality, we want to know what's been going on. So a very detailed history of the symptoms. And so we use the OLDCART, if you've heard of that before, to assess for symptoms. And so that stands for onset, location, duration, characteristics, aggravating factors, relieving factors, and time. So the characteristics itself means, is it sharp? Is it dull? Like those kind of characteristics. That's what that means. Does anything make it better? Does anything make it worse? And how long has it been going on? So that's a really good way to assess for symptoms. We talk about it a lot with pain assessment, which is really good for that as well. But any kind of symptom that a patient's having, using OLDCART is a really good way to get all of the information that we need. Does the patient have any other associated complaints with the symptom itself? Family history. Family history is going to be important when we're getting a history on any patient. Definitely with neurological abnormalities. Does anybody in your family have the same symptoms? Do you have a known family history of specific conditions? There are genetic neuro abnormalities, so we would definitely want to know that. As with every assessment, we need to know what kind of medications are you taking. Now, we need to know what every medication that the patient's taking, but definitely with neurological abnormalities, it's really important to know, are you taking any sedatives, opioids, mood elevating drugs, right? So those are all really important pieces of information when we're trying to assess for a neuro abnormality. Have you had any surgery or any other treatment? Particularly anything involving the head, neck, spine, eye surgery, anything kind of in that general area of the neuro system. But we definitely want to know, is the patient had anything at all in the past? So this table in your book, the 60.3, it's kind of a lot of information, and I just kind of wrote down the patterns on here briefly, but just kind of know that this is also another an additional way to assess for neurological abnormalities and going through these different patterns. And as you review that table and the more information under each of these, it makes sense why this would be a really important piece of the neuro assessment. So just make sure you review that table. Okay, so when we're talking about now our objective assessment, so we've completed our subjective assessment, now we're going to go to the objective assessment, the physical assessment for neurological abnormalities. So generally we follow this kind of list here: mental status, cranial nerves, motor system, sensory system, reflexes. So the first here is mental status. So general appearance and behavior. And when you first go into your patient's room, when you're taking care of somebody, you're immediately doing a mental status assessment. As you walk in the room, hi, my name is so-and-so. I'm going to be your nurse today. And your assessment starts right then. So keep that in mind too. So looking at their general appearance and behavior. Obviously, we're going to assess for level of consciousness, motor activity. As you come into the room, does the patient turn to you appropriately? Do they, seem to have motor activity abilities just as you walk in the room? body posture, dress, hygiene, facial expression, speech pattern. Those are all things that we would assess right away. And then, of course, we're going to assess for the patient's cognition. And you're already familiar with this, but is the patient oriented to time, place, person, situation? Noting memory, general knowledge, insight, judgment, problem solving, and calculation. That's all part of a cognitive assessment as well. So one example of that is asking a patient, what do you use to cut paper? Can you count backwards by 7? So, we often use our same questions like, do you know where you are? Do you know what the date is? Do you know who the president is? And so, not to say that those aren't good questions, but there are situations where patients already memorize those maybe until we're not really doing an accurate assessment. So understanding that there's other questions that we can ask that are better is important, especially if we suspect that there's a neurological abnormality, right? If the patient's there for something else and they don't have any neuro abnormalities, then some of our more basic neuro assessment questions are probably fine, but just keep that in mind. We often use the mini mental status exam too. So there's a table in a different chapter, in chapter 64, but I would like you to review that. So 64.10 to review that and just kind of understand that that's another assessment tool that's used. And then mood and affect. So do you notice, is the patient agitated? Are they angry? Depression, euphoria, appropriateness to these states. And so those are all part of our mental status exam. Okay, next up is cranial nerves. So there's a table in your book that is 60.4 that has lots of information about the cranial nerves. Please review it. Please have a really good understanding of the number, the name, and how we test for it, right? This is just a piece of being in nursing school that you have to memorize. So whatever it takes to be able to memorize this information. But we're going to go through all of them. Okay, so the first one, cranial nerve 1, is the olfactory, which is sensory. The way that we test that is to close one nostril and easily identify a recognized odor. So an example of that would be coffee or peppermint. Cranial nerve 2 is optic, so that is sensory as well. So that's when we assess for the visual fields and the visual acuity. So the visual fields is the peripheral vision, visual acuity is the Snellen chart, or a chart where you can kind of assess, is the patient able to read at a certain distance. So 3, 4, and 6 are typically tested together. They're motor and they are related to the extraocular movements. And so this is the cardinal fields of gaze, where you have your finger and you move to the 6 different places and have your patient follow your finger just with their eyes. So you're assessing for, are they able to do that? Do they have nystagmus, which is like a kind of a shaking of their eye? And then PERLA. So as you remember, PERLA is pupils equal, round, react to light, and accommodation. So making sure that we're doing direct and consensual pupillary response with the pen light. And then the accommodation. So remember, with accommodation, you have the patient look far away to see that their pupils dilate to see a far object, and then you bring something near and make sure that their pupils constrict to see a near object. And so that's the part of it. Sometimes we forget about the A part of PERLA, so just keep that in mind. So those are all testing for 3, 4, and 6. Okay, so 5 is sensory and motor, so the trigeminal nerve. So for sensory, this is when you have the patient close their eyes, and then you want to see if they can identify a light touch and pinprick in each of the 3 divisions. So you need to do both sides of their face in 3 different places, so 6 places total. The ophthalmic, maxillary, and mandibular. And so you just want to see if they can identify the touch in those areas. The other one is the corneal reflex, which if you lightly touch the cornea with a cottonousse, they should blink. So that should be their reflex. And then the motor part is clenching their teeth and palpating the masseter muscle. So you just hold your hand on either side and have them clench their teeth, and you should be able to feel those muscles clench. Okay, so cranial nerve 7 is facial, so sensory and motor. So with motor, we have the patient raise their eyebrows, close their eyes, purse their lips, smile, and frown. So that's how we assess for that. The sensory part is taste from a portion of the tongue, the anterior 2/3 of the tongue. The rest of the tongue is on a different cranial nerve, but that's how we would assess for sensory. And then cranial nerve 8 is the vestibulocochlear, which is sensory. Typically, the easiest way to do that is closing eyes and identifying when they hear rustling of fingertips on each side. They also can do the Weber or the Rennie tests, which are tests that involve a tuning fork. And we won't go into too many details about that. There's not always like a tuning fork available to assess for that, but just so you know that those are additional tests associated with assessing cranial nerve 8. So 9 and 10 are often tested together, sensory and motor as well, taste from the other portion of the tongue, the gag reflex, and then the soft palate. So having the patient say ah and make sure that the soft palate rises. Okay, so accessory is a motor shrugging shoulders and then turning the head either side to side with resistance. So making sure that the patient actually has that ability to shrug the shoulders with your hands on top of them and then turning their head side to side with resistance. And then 12 is motor, so that's protruding the tongue, moving it up to down, side to side, and then pushing the tongue to either side of the cheek against resistance as well. Okay, so moving on to the motor system. So the first thing you would do to assess for symmetry. So that is like oftentimes a visual assessment. You know, do I see that the motor system, you know, seems to be the same on either side? The next one would be strength. So we often do push-pull against resistance, and so that's important when it comes to strength, is having resistance. The other one is the pronator drift, and so having the patient have their upper extremities held up with their palms up. And what you may see is that if there is an abnormality, the patient may have what's called pronator drift of their hand kind of coming down, like their palm facing the ground and kind of coming down. So that would be an abnormal finding. The next one would be tone. So passively moving the limbs through range of motion. There should be a slight resistance from the patient. Abnormal tone, we can kind of have two different kinds. So flaccidity of tone, which would be called hypotonia. So the patient's, you know, having no tone whatsoever, or hypertonia, which is spasticity. So that would be where they are having an aggressive kind of response or an aggressive spastic kind of response as you're assessing. Okay, the next one would be balance and coordination. So we talked about cerebellar function associated with that. So the cerebellum is associated with balance and coordination. So simply watching a patient in their stature and their gait is an assessment of cerebellar function. So noting their pace and rhythm as they walk. Do they have symmetric and opposing arm swings? And the finger to nose test is another one that you can do. So you have the patient alternately touch their nose and then touch the examiner's finger. So you, as the examiner, are going to hold your finger out and have the patient touch your finger, but then you need to move it to different positions and then see if the patient can actually touch as the examiner's finger. And so if they have an issue, they may not be able to, they may miss the finger, they may just not be able to you know, get close to it at all. And you also need to, as the examiner, kind of make sure that your finger is not, it's kind of back far enough that the patient actually has to reach for it a little bit. So that's another assessment piece there. The other one is the heel to shin. So you should have the patient stroke the heel of one foot up and down the shin of the opposite leg. So this can be done standing or laying down. So if you have a patient who's not mobile, you can do that laying down as well. So that's a way to assess cerebellar function. Okay, so with the sensory system, and it's important to know if you're assessing the sensory system, you need to make sure that you have your patient close their eyes, because they may, whether it's intentional or not, they may kind of cheat a little bit if their eyes are open. So just make sure that you have them close their eyes. The things that we talk about the most are touch, pain, and temperature. So when we talk about touch, it is identifying sharp and dull. And this can be, sometimes it's like a cotton tipped swab. So you can use the cotton tip for dull and then the other end for sharp. Obviously, we don't want it to be too sharp and actually harm our patients, but you want to assess both sides. So we want to know, is it bilateral? Is there a problem only on one side where they can't identify between sharp and dull? And this is something that you would often see in a patient with neuropathy. They just might not be able to feel it at all, or they may not be able to identify between a sharp and dull sensation. And so the other thing is extinction, which is touching both sides at the same time. So just a simple touch on both, let's say, lower extremities. Can they feel it on both sides? And sometimes the patients can only feel on one side, so that would be an abnormal finding. The other one is temperature. So you can do, sometimes they do like the back of your hand that may be warm, or I think your book talks about having like tubes of cool water and warm water. So can the patient identify the difference between a cold or a cool and a warm sensation? The other one is vibration sense. So this also has to do with the tuning fork, which is not always readily available, but if you have a tuning fork, you can put that on the like a bony prominence and see if the patient can actually feel the vibration sense. Position sense or proprioception is another sensory test. So you can assess that by doing the Romberg test, which is having the patient stand with their feet together and close their eyes. So the patient should be able to maintain balance. Sometimes there's a little bit of sway, which would be okay. But if the patient actually ends up falling over or almost falling over, then that would be an abnormal finding. So if you're completing the Romberg test on a patient, particularly if you expect it to be abnormal, you want to maintain patient safety. You want to be right there. Typically have kind of your arms out a little bit to make sure that the patient doesn't actually harm themselves if they do fall. Another couple tests are the cortical sensory function tests. The 2-point discrimination is one of them. So what you can do is for the 2-point discrimination is you typically have something with like an example is like calipers that we use for EKG determination or interpretation, where you have 2 points that are a certain amount of space apart, and see if the patient can determine that there are 2 separate points. And then you get them closer and closer together, and then you document at what point does the patient only feel 1 point versus feeling 2 different points. And it may be that they don't feel 2 points at all, and it may be that you have to assess at what point do they only feel 1. And the graphesthesia itself is, can the patient identify numbers traced on their hand? So you would have them close their eyes, have their palm facing up, and you would trace basically, let's say, a number 8 on the palm of their hand. Can they identify that you trace the number 8? The stereognosis is the patient able to identify easily recognized objects? So like a paperclip, for example, if you put a paperclip in the patient's hand with their eyes closed, would they be able to tell you that that's a paperclip? So a lot of these, are pretty detailed, and it may be some things that you only really see if you work in a specific neuro unit, but it is important for you as nursing students to understand all of these tests and why we would test for them. The next one would be reflexes. So we have a reflex is a contraction of a skeletal muscle that occurs when the tendon is stretched. So you may be the most familiar with the patellar reflex, which is one that's typically assessed, but there are several different reflexes that are assessed. And when we do it, the value is 0 to 5, and 2 is a normal response. If a patient has what's called clonus, which is an abnormal finding, that would be a continued rhythmic contraction. So clonus is continued reflexes, and so that would be abnormal and oftentimes associated with a abnormal neuro condition. Okay, next we're going to move to diagnostic studies. So one of the diagnostic studies that's used the most is a CT scan. Sometimes people say CAT scan or CT scan. But the thing about a CT, why it's used so often, is that it's rapid imaging. So a patient can get into the CT machine very quickly and can get really good information very quickly. There are CTs with contrast and without contrast. So what I mean by contrast is we can use material that is injected to the patient, sometimes in an artery, sometimes in a vein, depending on what we're doing, just when we're talking about contrast in general, and using imaging to kind of get a better picture of what might be going on. That being said, contrast is not always appropriate for every patient for a variety of reasons. So a non-contrast CT is something that is associated with neurological abnormalities that can be done very quickly to give us a really good amount of information. So a non-contrast CT is going to be something that you'll see comes up over and over again with neuro abnormalities. The other one that we'll talk about a lot is a lumbar puncture. So a lumbar puncture is actually a needle inserted into L3, L4, or the L4, L5 interspace. And we can put a needle into that space and I'm going to attach a manometer that actually gives us a numerical pressure number. So when we talked about at the beginning of this PowerPoint, monitoring the cerebral spinal fluid pressure and monitoring for increased intracranial pressure, this is what I was talking about. So they get in there and they can have an actual value that tells us, is this patient's intracranial pressure, elevated. They can also tell on a CT to a certain degree if there is increased intracranial pressure, and we'll talk about that in a different chapter as well. Oftentimes the fluid that's aspirated, the cerebral spinal fluid aspirated during a lumbar puncture, is sent for analysis. They want to test that fluid and see what might be going on, and this is going to be associated with lots of conditions that we talk about. It is important to know that a lumbar puncture is contraindicated in the presence of increased intracranial pressure, because if you have a large amount of pressure in our system and we rapidly reduce that pressure, it can cause herniation. It can cause the brain tissue to herniate into those ventricles. It can cause brain stem herniation, meaning that the brain stem itself gets kind of squeezed, which is not a good thing. And we will talk about this a little bit more as well, but those are kind of the main takeaways for this point, for this PowerPoint of the diagnostic test lumbar puncture. Please review the tables in your chart or in your textbook, 60.7 and 60.8. So those are additional information associated with lumbar puncture. So this is an important piece. The next one is an MRI. So an MRI does provide greater detail compared to a CT, but it is not a quick test. It takes a longer time to complete, and there are a lot of things that the patients need to be assessed for prior to receiving an MRI. So they have to make sure that there's no metal objects, that implants that the patient may have. They also need to look through the patient's history to kind of document anything that could have a potential impact to the MRI. So it's not a quick test. So it does give us better information, but it's not appropriate in many conditions. It may be something that's completed down the road once they know what's going on, but in terms of a quick test, that non-contrast CT is going to be the thing that we do first. The next one is a PET scan that we talk about often. It uses radioactive material and it measures metabolic activity. So this is kind of under the same category as MRI, in that depending on what's going on, the patient's likely to have a CT and then have some additional testing kind of once they may know what's going on and what's the patient's somewhat stabilized. So the PET scan is kind of under that category as well. And sometimes patients will have an angiography. What an angiography is accessing an artery and visualizing the blood vessels using contrast. So this is kind of a type of test that comes up in several different systems. So cardio system, for example, this is accessing an artery, injecting contrast, using x-ray to see if there's any issues within the blood vessels themselves, and most often the arterial system versus venous, but it can be both. So kind of in the beginning of this PowerPoint, we talked about the arterial cerebral circulation, and we'll talk more about that with stroke. But this would be a procedure to kind of see what's going on with the actual circulature, the circulation of the system, and potential impact to see if there's something that can be done about that. Another diagnostic test is a EEG, which is electrical activity of the brain using scalp electrodes. And this is oftentimes associated with determining if the patient has no brain activity. So this is a test. It can test for lots of different things, but it's oftentimes associated with that. The key with an EEG is understanding certain medications need to be held because it may impact the test. So sedatives, seizure medication, different neurological medications may impact the accuracy of the test, so they may need to be held. So there may be some potential impacts to the patient if they're unable to take their meds that they need to be on. So sometimes these are also tests that are kind of down the road a little bit too when we're trying to figure out what might be going on with the patient. An EMG is an electrical a test that's associated with the activity and innervation of skeletal muscles. So that's another test that we may see. So these are very important tables in your textbook. So please make sure you review both of these tables that give you a large overview of normal findings and abnormal findings. We will talk a lot about abnormal findings as we progress through these neurological PowerPoints and different conditions that we talk about and what you might see. And these tables just give you a really good overview of abnormal and normal findings. So please make sure that you review those. I'm just going to talk about a few of the most common abnormalities. And again, these will all come up in different PowerPoints, but I just wanted to include them on this assessment PowerPoint to just kind of have some extra time to talk about them. So one we'll talk about is some language abnormalities. So the first one we'll talk about is something called global aphasia. And this is something that a lot of patients have, which is severe communication difficulties. Patients may be limited in their ability to speak or understand language. So we'll talk about this a lot with stroke as well, but many patients with neuro conditions have some type of global aphasia, limiting their ability to speak and their ability to understand language. And then we're going to talk about fluent or receptive aphasia, as well as non-fluent or expressive aphasia. So fluent or receptive aphasia is a place in the brain called Wernicke's area, which is in the temporal and parietal region. And the patients that have fluent or receptive aphasia have difficulty understanding speech. So if you look at the name of receptive aphasia, it means that they are not receiving the information correctly, right? So they're having difficulty understanding what other people are saying. So they're often unaware of that, and they may speak in sentences that have no meaning or add unnecessary words, and it's because they're not receiving the information appropriately. Now, it's important to note that their speech ability is normal. They have the capability of speaking normally, but it's often not what they should be saying because they're not receiving the information correctly. As opposed to non-fluent or expressive aphasia, which is something related to Broca's area in the frontal lobe, their comprehension is intact, but they are not able to speak appropriately or express themselves appropriately. So because of that, they often speak in short phrases and often omit like small words. So we speak in, full sentences, and they will often skip the words like and or of or an, can, be, those small kind of words that kind of make a sentence a full and complete sentence. They oftentimes omit those or are unable to say those because of those expressive inabilities. And the thing that's really sad is because they're often very aware of the difficulty, so they can become frustrated. So again, their comprehension is intact. So that's where the frustration really lies. Now, not that both patients can't get frustrated, but there are key differences between the two. So please make sure you have a good understanding of the differences between these two types of aphasia. Okay, level of consciousness. This is a really, really important piece here. So when we talk about level of consciousness, please know this is the most sensitive and reliable indicator of neurological status. When we talk about a patient being unconscious, that means an abnormal state of complete or partial unawareness of self or environment. So patients are, the term unconscious can mean lots of different things, but please know that unconscious doesn't mean pulseless, or unconscious doesn't mean that they're not breathing, right? We would, of course, if we have a patient with a change in level of consciousness and we suspect them to be unconscious, we would assess for those, but don't assume that because a patient's unconscious that also means that they are pulseless or they're not breathing. Now, the key with changes in the level of consciousness is understanding that they may be very subtle. It would be a lot easier if a patient had a change and it was a very obvious, right? Completely alert oriented, all that, and then just immediately changes to a completely different consciousness state. That would be much easier to determine and to assess for, right? But oftentimes it is very subtle. So they may start being more restless, have some increased anxiety, their affect may change, they may have those subtle changes in those orientation questions. So just keep that in mind. Also, when we talk about coma, that means the deepest state of unconsciousness, not responding to painful stimuli, corneal pupillary reflexes absent, cannot swallow or cough, incontinent of urine and feces, EEG pattern shows suppressed or absent neuronal activity. So those are the characteristics of coma. Now, the key with this is understanding whenever I say or we say that a patient cannot swallow or cough, that should be a red flag, red flashing light to you. They cannot protect their airway, right? So please keep that in mind. We are concerned about airway, among other things, with a patient in a coma, but seeing those words of cannot swallow or cough should be a red flag of airway. All of the things listed here are obviously very important as well, but just please keep that in mind when it comes to coma. Or any patient who cannot swallow or cough, right? Those are all always associated with an inability to protect their airway. Okay, we often use the Glasgow Coma Scale, or the GCS, to assess level of consciousness. Please review the table in your textbook 61.5, but it is a standard system for assessing level of consciousness. And there are three components: eye-opening, verbal response, and motor response. The higher the score is the higher level of brain function. The highest score is 15. We would love for every patient to be at 15. The lowest is 3, so that would only be 1 point per item here. Please keep in mind, a Glasgow Coma Scale of 8 or less generally indicates coma. So that is an emergency, right? That is a patient, obviously, if it's a new finding, that is definitely an emergency, but understanding what does that mean if a patient is in a coma? What things do I need to keep in mind? Also to keep in mind is that a Glasgow Coma Scale, parts of that may be untestable based on the patient's condition. They may not be able to have a verbal response, right? They may not be able to open their eyes appropriately. So there's other ways to assess for level of consciousness. This is generally the one that's used the most, but know that it's not a perfect system, and there may be other ways that they're assessing level of consciousness. So here's all of the numbers associated with assessing for the Glasgow Coma Scale. So you can see the eye opening, the verbal response, and motor response. And so those are all the ways that we would assess for it, or our findings, and then you would assign the appropriate number and then add them up together to get the total score. Okay, we talked a little bit about assessing for painful stimuli with the coma patient. So how do we assess for painful stimuli, right? And so I just wanted to include a slide about that. It kind of sounds a little barbaric, like we're trying to hurt our patient, but assessing a patient to see if they respond to painful stimuli is really important. That's a huge piece of our assessments, right? And so typically they will assess the central do a central type assessment first. So a trapezius pinch is one way, and that's actually pinching the trapezius muscle itself to see if the patient responds to that. Other things that they can do is actually a nipple twist to see if the patient responds. Orbital pressure is another one. There may be contraindications, especially if the patient has fractures or any kind of like damage, facial damage or anything like that. So that may not be used. It used to be that a sternal rub was the kind of standard for painful stimuli. It's not always used first anymore. And part of that is, actually rubbing a patient's sternum could cause tissue damage, particularly if they were on medications such as blood thinners that you may end up causing like bruising or tissue damaging. So also, would need to be cautious for that. So these are different ways of assessing it, and it may be patient specific how the painful stimuli is assessed. Another way to do it is pressure on the proximal nail beds. So that's another way that's more of like a peripheral type of assessment, but that may be something that is done as well.